Hello, and welcome to today's episode of Uptime, the podcast from .med's Healthcare Business News. I'm Carrie Stevens, your host. In this episode, I'm joined by Axel Wirth, Chief Security Strategist at MedCrypt and a leading voice in healthcare cybersecurity. We'll explore how HTM and clinical engineering teams are navigating increasing cybersecurity demands while still maintaining uptime, managing risk, and supporting complex, connected healthcare environments. Axel, thanks for joining me today.
You're welcome, and thanks for inviting me.
Of course. So healthcare is still struggling with legacy thinking around cybersecurity. So where do you see the biggest gap today between how hospitals would think risk is managed versus how risk actually exists on the network?
So healthcare as an industry has for many years, if not even decades, been driven by regulations and compliance with those regulations, right? It's HIPAA on the hospital side, it's the FDA on the manufacturer side, the vendor side. And I think that has worked against a nimble and solid security approach. Right? I think being compliant doesn't necessarily mean that you're also secure. Being compliant defines your posture relative to laws and regulations. Being secure means that you can protect yourself against somebody who doesn't follow laws and regulations, right? Cyber adversaries, cyber criminals, nation-state hackers, and so forth. So I think healthcare really is a little bit behind in recognizing this. Yes, there are regulations and laws I need to comply with, but at the same time, I need to build a security posture that can withstand attacks.
Great. And so you've talked about cybersecurity needing to follow the full device lifecycle. So where does that responsibility most often break down in practice? Procurement, implementation, or post-deployment management?
So looking at it from the hospital side, the HTM side, I think it is really security needs to be considered from the beginning, or even actually before the beginning. Right? Think about replacement planning. Think about new equipment you're about to acquire. You already need to think about security, how you will protect it, how you will integrate it, and so forth. And then, yes, you already mentioned procurement. That is the first step where you will engage typically with your suppliers, with your vendors, with manufacturers, where you need to articulate what your security expectations are. And you need to then make sure that you get the appropriate response from the parties you're engaging with, that they confirm that they can meet your security requirements, that they have the level of maturity that you're expecting. And that maturity is on the technical level, as in, can the device withstand an attack? It's on a procedural level, as in, will the manufacturer support you through the use of the device? And it is also lastly on a contractual level to make sure that the manufacturer is willing to sign the contract that stipulates, of course, all of their requirements, but including cybersecurity.
Great. And SBOMs, or software bill of materials, they're frequently positioned as a foundational tool for visibility. But in your view, what's still missing to make them truly operational in day-to-day hospital security programs?
So SBOM, software bill of materials, right, is basically the ingredients list of the software that runs your device, right? It defines every single piece of code in there, be it open source, be it commercial, be it contracted, be it custom written for your device. And in theory, that list of ingredients allows you to identify risks and vulnerabilities. You know if a new vulnerability is published either by a software supplier, companies like Oracle, Microsoft, you name it, or if a vulnerability is published for an open source component. In theory, you get a head start in knowing about it, right? In practice, complexity is your enemy, because devices contain highly complex software with thousands, if not tens of thousands of individual software components. They need to be analyzed and then matched against an equally long list of possible vulnerabilities to determine whether that vulnerability is on the device, and then you need to interpret whether that actually is a risk for you as an organization. Merely the fact that a vulnerability is on a device doesn't mean that the implementation, the way the device is built, is actually exploitable and is a risk to you, right? So there are data complexities, there are decision complexities. The data is not black and white. There's a lot of interpretation, a lot of gray zone, and so forth. So it's the complexity that today prevents SBOM from being the miracle cure that many think they will be in the future. We need to develop and establish practices and automation that allow hospitals to go through thousands and thousands of individual software components, match that against 10,000s of vulnerabilities that are out there, and hundreds, if not thousands, added on a regular basis, and then make the right decision quickly to determine again whether I'm exposed or not. And I can overreact, and that is wasted time, valuable resources sent to do something that is not constructive to cybersecurity. But it can also be missed risks, that there are risks that I need to protect, and I don't realize that I'm exposed and don't take action. So the errors can occur on both ends of the spectrum.
Great. And you and I actually got to speak together at Amy, the recent Amy show, earlier this month, well, earlier in June. And one of the things we were talking about is whether, medical device could really, basically the patient and care impact of a healthcare cyber attack. Can you talk about that a little bit?
Yeah. What we know today is that we had 2 cases of a patient death due to a cyber attack, but it was not the attack on a specific device with the intent to do harm. It was in both cases, a communication breakdown across the care team. And in one case in the UK, it was a communication breakdown between hospitals and a pathology service provider, delivering results back to the hospital too late, resulting in several cases of delayed procedures and patient harm, and one attributed death. And then the other case was here in the US, where a decision about a C-section during a complicated delivery was made too late because the care team, under a cyber attack, did not communicate in a timely manner, and the decision was made too late. And the baby, unfortunately, was harmed and passed away a few months after birth. So those are certainly really tragic accidents and wake-up calls, right? But what we also need to consider, and I think that is today the prevalent problem we're dealing with, is systemic impact across a larger organization, right? Not a specific patient getting harmed because of a specific device being impacted, but because something not running smoothly, something being delayed a little bit there, and that those minutes of care delay statistically lead to an increase in mortality rate. Right? And we've seen several studies now, credible studies by people who know what they're doing, that demonstrate exactly that scenario. Right? It's not that one big bang that should wake you up. It is the subtle creep of, again, a minute longer until an emergency patient gets an EKG, a CT scanner not being available at one hospital, patient have to be sent to another hospital, and those cumulative delays then lead to a statistical increase in mortality rate, which then, of course, is a loss of human life in the end.
Absolutely. Very scary. And A lot of organizations still treat cybersecurity as an IT function rather than the clinical operations issue. So, what does it look like when a hospital actually bridges that device well?
So in many organizations that still have a traditional structure, traditional organization, IT and IT security functions are separate from clinical engineering and HTM. And that leads to unclear responsibilities, which, back to your very first question, starts at the point of purchasing. Right? I buy a new medical device that's going to be on my network. Well, who makes the decision that the security of that device is sufficient to be on my network? Right? That needs to be a joint decision between all involved, including IT and including clinical engineering. But that continues throughout the entire life of the device. Right? Make sure that communication flows between the teams. Make sure that responsibilities are clear, that there are no gaps. Make sure that there's no hostility between teams, right? That they are willing to communicate and be open rather than protect their turf and blame somebody else if something goes wrong. And I've unfortunately seen very ugly scenarios in that regard. I think the hospitals that have made the biggest progress are the ones that opened up their team, made it a shared responsibility with a signed and clear-cut definition on who takes care of what. Most commonly, it's clinical engineering responsible for the device up to the network plug, and then IT and IT security after the network plug. But still, with the complexity of today's information flow inside the hospital, but also external to any cloud service provided and so forth, it is never just a clear line. People need to talk. People need to, be able to respond appropriately if a problem occurs.
Great. And we often talk about presenting breaches, but less about resilience. So, what does good resilience look like in a real clinical environment when a device or system is compromised?
Yeah, very good question. Obviously, it is initially about preventing an attack of being successful, like compromising a device. But what is another important factor is, as you were saying, resilience. How quickly can I recover? How well can I manage through the time of recovery? Right? And that philosophy is true for the individual device. Does the device have a fail-safe mode providing minimal service while, for example, the network around it is compromised? Right? But also, how easy it is to restore the device after an attack, get it back integrated into whatever it needs to talk to, and make sure that that functionality and the data flows again. Right? Again, resilience is certainly what influences the impact. If I keep minimal functionality alive, then I do less harm. And it is a matter of recovery, as in the sooner I recover, the less harm is done.
Great. And as a last question, I ask every guest on Uptime, what is keeping you up at night? And specifically in regards to medical device cybersecurity?
Um, I think it's a matter of progress and a matter of determination and speed. Right? I think we've seen, and I mean, I've been dealing with the topic now for 16 years, give or take. And yes, we've made great progress in that time, but we still don't move fast enough. But every new device that is being designed by a manufacturer, that is being purchased by a hospital, that doesn't include top-notch security, becomes a risk for the next 10 years. We need to break that cycle, and we need to get ahead of the cycle. And yes, many manufacturers out there now have strong security teams and are building very secure devices. But we need to spread that good news across the entire industry. And we need to make sure that we don't push that final target of having everything on our network sufficiently secured out too far.
Thank you, Axel. This was great. And to our listeners, thanks as always, and be back for the next episode of Uptime. I'm Carrie Stevens. Take care.
Thanks for having me.